Ahlan bikum. Today we're going to continue our study of the neck. It's the posterior triangle now. Boundaries. First of all, let's identify the triangles of the neck. There is a key muscle, the sternocleidomastoid muscle, originating from the manubrium and clavicle and going to the mastoid process of the head. Its oblique course divides the lateral view of the neck into two main compartments. The anterior compartment, the anterior triangle, has the mandible inferior margin as a base, and the posterior triangle with the clavicle at the base. Note that the two triangles are opposite each other. One, the apex at the top, and another one, the apex is down below. The anterior triangle is further subdivided by muscles. When we reach there, we will describe in detail. But now we are concerned with the posterior triangle. This is the area of the posterior triangle, bounded anteriorly by the posterior border of the sternocleidomastoid, posteriorly by the anterior border of the trapezius muscle, and inferiorly by the clavicle, middle third of the clavicle, because it's taken medially and laterally by the insertion of muscles. The floor is apparent in this specimen, mainly made of muscles, and the roof is the skin, the fascia, superficial fascia, and its contents. Now, before going through the posterior triangle, let's talk about the sternocleidomastoid. Embryologically, the sternocleidomastoid actually is the two muscles fused together, and we know that the spinal accessory nerve pierces the muscle. Actually, it passes between the two embryological muscle origins of the sternocleidomastoid and supplies both, of course. It arises by two heads. Medial head, which is tendinous, rounded tendon arising from the manubrium of the sternum, and a lateral rather fleshy head or broad head that arises from the medial third of the clavicle. The two heads join together and form the bulk of the muscle that runs upwards and backwards to the surface of the mastoid process, backwards along the superior nuchal line to meet the edge of the trapezius. So it's a powerful muscle. It's unique in action, and its importance in dividing the neck into triangles. Now, what's the purpose of triangles? It's only for descriptive purposes. I mean, if you are in emergency unit and you receive the case of a lesion in the neck, you need to write down the exact location of the injury in the neck. So you refer to posterior or anterior triangles to describe your the lesion. Now notice that the sternomastoid has two heads. Apparent in between is the internal jugular vein. This can be used as an axis for a CVP, or if you want to just cannulate the internal jugular vein, go through these two heads and you are there. The muscle is pierced and supplied by the spinal accessory nerve. We will come to the course of this nerve later in lectures, but I want to talk about something. All muscles receive motor nerve supply, and they send sensory nerve supply. That's called the proprioception, deep sensations. It sends information about the status of the muscle. Is it fully contracted, fully relaxed, tone, other components of proprioception from the nearby joints sends continuous information about the status of the joint, flexed, extended, and so forth. It receives sensory the sternomastoid receives sensory branches from C2 and 3. They are for proprioception, and don't forget that when you talk about the nerve supply of the sternomastoid. Certain muscles, you have to mention these. Of their importance, maybe of their importance, or because bulky muscles, whatever the cause may be, you will encounter this info in your when solving multiple choice questions. Now, the action of this muscle, when it acts alone, individual, not organizing the action with the other muscle, it will pull the insertion towards the origin, means it will pull the mastoid process towards it, which results in lateral flexion and rotation of the head to the opposite side. Rotation to the opposite side. So the left sternomastoid turns the head to the right, right sternomastoid turns the head to the left. How to test that? Ask the patient to turn his head against your resistance. Now there is a condition worthy of noting here, the torticollis. Torticollis is a state of continuous contraction, continuous intermittent contraction of the sternocleidomastoid. Of course, it results in extreme pain because of the contracted muscle, and sometimes it's associated by fever. It takes several days to pass through, and needs you may improve it by of course, according to the cause of this torticollis. You can relieve it by physiotherapy. Now, for the contents of the triangle, we have the roof, which is skin, fascia, superficial fascia, with platysma in it. Now, in this specimen, it's removed. What else do we have? We have cutaneous nerves. See that? Cutaneous nerve reaching the skin to bring sensory information. What else? We have a major vein, external jugular vein. We have the accessory nerve, the spinal accessory nerve. There it is, and we will talk about it. Now, for the cutaneous nerves, they are counted as content of the posterior triangle because they emerge from the back of the posterior border of the sternocleidomastoid. That means in the posterior triangle. We have ascending nerves like the lesser occipital nerve, this one, the one you see going behind the ear. It shares and supply the occiput and the ear pinna as well. This is called the lesser occipital nerve. The great occipital nerve, it's an important nerve that runs on the sternocleidomastoid and goes towards the parotid, see that? And splits to supply numerous branches to the capsule of the parotid, as well as the skin over the angle of mandible. It receives C2 from here, so this is extremely important. When you examine the nerves of the face, that is the ophthalmic, maxillary, mandibular nerves, don't examine the skin over the parotid and angle of mandible because it's supplied by C2 from the great auricular nerve. See that? This is an important clinical information. We have another cutaneous nerve, the transverse cutaneous nerve of the neck. It splits into ascending and descending branches to cover the area. We have group of nerves called the supraclavicular nerves. See that? Divides into medial, intermediate, and lateral groups. Now, they carry C3 and 4 sensory information to the CNS, but I want you to notice the lateral group. The lateral group, actually, it takes part in the supply of the skin over the deltoid muscle in the shoulder, upper arm, and this carries C4. Now, if there's a condition where you want to examine C5, for example, that is over the upper arm, and skin shoulder as well, shoulder skin as well. You don't go high up. If you go high up to examine C5, you will get false positives. Means the patient, when you strike it with a needle there, prick it with a needle, the patient will tell you that he sensed the needle. He sensed the needle with his C4, not C5. C5 may be damaged. So you should go to lower levels, actually at the point of insertion of the deltoid muscle, and you examine there for C5, you're safe. This is important clinical information about the lateral group of the supraclavicular nerves. We're still talking about the contents of the posterior triangle. Now we will come to a very, very important nerve, the spinal accessory nerve. The spinal accessory nerve has a unique course. It arises from C1 till C5 or 6 spinal cord segments inside the vertebral canal. As forms, they unite together to form a single nerve that ascends upwards, enters the foramen magnum, meets the cranial accessory nerve, which is cranial nerve number 11, then leaves it again after a very short course and goes down the spinal accessory, goes down the jugular foramen to come to appear in the neck, goes down and lateral, pierces the sternocleidomastoid, then comes out of the sternomastoid and goes further down and lateral to end by supplying the trapezius nearly at midpoint of the anterior border of trapezius. This is the spinal accessory nerve. I told you before that some books consider this not part of the superficial fascia, but between the superficial and the investing layer. Whatever, it doesn't make a difference. It is superficial. It is superficial, so it's liable to injury. Now, let's talk about this. Suppose you have an injury, you get a case of an injury of the spinal accessory nerve in the anterior triangle. The patient will end up paralyzing the sternomastoid and the trapezius. When you ask him, for example, if we are talking about the left sternomastoid, he won't be able to turn his head to the right against resistance, and he won't be able to shrug his shoulder against resistance because the trapezius is paralyzed as well. See that? So injury in the anterior triangle, and you will encounter this in USMLE and MRCS questions. Injury in the anterior triangle results in paralysis of both muscles, the sternomastoid and trapezius. But injury in the posterior triangle, which is more common, you will get that with people carrying heavy weights like the AC porters. In motorcycle accidents, it's very common injury that it gets injured in the posterior triangle. Now, the sternocleidomastoid is already supplied by the nerve, so it's saved. The patient has no problem in turning his head, but the only muscle affected will be the trapezius. So he will get inability to shrug shoulder against resistance on the side of the lesion. See the difference between the two injury sites? Injury in the anterior triangle, injury in the posterior triangle. Now, if you want to know a surface anatomy of that nerve, see the posterior border of sternomastoid divided into 3. Junction of the upper third and lower 2/3. Draw a point. And anterior border of trapezius, draw another point at the middle of the way, mid distance in the anterior border of trapezius, and draw a line. This will be the spinal accessory, the surface anatomy of the spinal accessory nerve. It's very important, this nerve. Please do not neglect it. Now, the spinal accessory, when descends down to the neck, It's accompanied by number 9, 10, and 12, the glossopharyngeal, vagus, and hypoglossal, respectively. Inside the carotid sheath, remember that the nerve has to be inside the carotid sheath, high up in the neck. Then it pierces the carotid sheath and goes out and pierces the sternomastoid, then ends in the trapezius. Please do not skip this nerve. Spinal accessory is very unique nerve. Now the floor. The floor is muscular. Many muscles you see there. Starting with the scalene anterior muscle, scalene medius muscle, scalene posterior muscle is hidden and rather down. Levator scapulae muscle, actually it looks like muscles, many muscle bands uniting together. Splenius capitis muscle, and this is a muscle that belongs to the back, means that it's supplied by dorsal rami of spinal nerves, not ventral rami. We will talk about this later. You may get occasional muscle at the very apex of the triangle. It's called the semispinalis capitis. So splenius capitis is there. Semispinalis capitis may appear at the very apex of the triangle. See, it's easy. The scalene, anterior, middle, and posterior, levator scapulae, splenius capitis, semispinalis capitis. The last two muscles are muscles of the back. Okay? What else does it contain, the floor? It has, see those thick nerves? Those are the trunks of the roots and trunks of the brachial plexus. It's the plexus going to supply the upper limb. What else will you find in this triangle? The subclavian vessels, the third part of the subclavian artery and the beginning of the subclavian vein. You will find them here. What else? Another muscle that has two bellies, omohyoid, superior belly, inferior belly. The inferior belly of omohyoid is a content of the posterior triangle, and some people use it to subdivide the triangle into supraclavicular part, which has the third part of the subclavian artery, and an occipital part, which has the rest, the muscles and the brachial plexus. Okay, so very simple. Scalene, anterior, medius, posterior. Now behind the anterior are the subclavian artery and the brachial plexus. Another two, the levator scapulae, two muscles belonging to the back, splenius capitis, semispinalis capitis, and semispinalis capitis is occasional muscle. Don't forget the omohyoid, and that the inferior belly subdivides the triangle. And in addition, we have collection of lymph nodes. Now the lymphatics I'm postponing till the end of the head and neck course. Now let's talk about the muscles we just saw now. It's called, actually, in general, called the prevertebral muscles. Prevertebral muscles. But this is a misnomer because, prevertebral muscles, and then you will start learning about the scalene, anterior, medius, and posterior. Look at this specimen. There are a group of muscles in front of the vertebral column. These are the prevertebral muscles, like the longus capitis, like the longus colli, like the rectus capitis lateralis, rectus capitis anterior. See those? All these muscles lie at the front of the vertebral column. They are called prevertebral muscles. This is the proper naming. Prevertebral muscles are those muscles. While the other muscles, the scalene, anterior, medius, and posterior, levator scapulae, they lie at the side of vertebrae. So actually they are called paravertebral muscles. But I told you, in general, it's known in anatomy. When you talk about prevertebral muscles, you include the whole thing. But the proper naming, these are called the paravertebral muscles. which are the scaleni, anterior, medius, and posterior. And you can go back to the levator scapulae. Now, there is an occasional muscle called the scalene minimus. Now, see this space in the concavity of the first rib? The upper part of the pleura comes here, ends level with the neck of the posterior of the neck of the first rib, posteriorly, while anteriorly it's a higher level than the manubrium and rib, because as you see, the thoracic inlet is oblique slope, has an oblique slope, anterior being more inferior than posterior. So the lung reaches, actually the pleura reaches the neck of the first rib. So we have a pleura in the neck. We have access to pleural cavity in the neck. Remember this when dealing with neck injuries, especially deep ones. The patient might be in a pneumothorax, case of pneumothorax, lung collapse, because the pleural cavity has been compromised in this area. Now, for this pleura to keep hanging up, to be pulled up, to keep pulled up and not go with the down with the movements of the lung, it's held in position by a ligament. It's called the apical ligament. Connects the apex of the pleura to the transverse process of C7. Transverse process of C7. It's called the apical ligament. Within this apical ligament, you might find some muscle fibers, and then you can call that the scalene minimus muscle. Okay? Just, it was worth noting. Look at this. Now, the scalene anterior muscle is the most important anatomically here because it's the key to its relations is the key to describing the anterior triangle. Look at this. These are the margins of the scalene anterior muscle. It's a big muscle going to the tubercle on the inner side of the first rib. It's called the scalene tubercle, while by the way the medius and posterior might go further down below first rib, go to the second or third ribs. See the scalene anterior? Anteriorly it has the carotid sheath with contents, lower contents of course. It has the phrenic nerve crossing it from the lateral to medial in front as well. It has branches of the thyrocervical trunk crossing to the posterior triangle anterior to it. Medially, all these structures, we will talk about that later in the root of the neck. The vagus nerve branches, the sympathetic chain branches, and branches of the first part of the subclavian artery, and the subclavian vein, the end of it. Now, note that the subclavian artery passes behind the muscle. It makes a groove on the first rib. It's groove for the subclavian artery. Now, this anatomical relation divides the artery into three regions. First part, before, from the beginning, origin of the artery till the scalene anterior. Second part, behind the scalene anterior. Third part, post, that is after the scalene anterior, lateral to scalene anterior, going to continue in the upper limb as the axillary artery. See that? This is very important because we will be describing the anatomy of the subclavian artery according to this relation. Its relation with the scalene anterior muscle. Look at this. See those thick nerves? Now, behind the scalene anterior, the roots and trunks of brachial plexus, we will get to that later. It's very prominent here, but this is part of the floor of the posterior triangle. So don't please skip, of course, never skip this muscle, the scalene anterior muscle, because what it does and its key relations in describing the area. See that? I want to show you something here. I hope I get it. See? This is the scalene anterior muscle. And while zooming, see, this will be the scalene anterior muscle. This is the internal jugular, and this is the left side, by the way. See those thick nerves? These are the roots and trunks of the brachial plexus. Now, if you know that the upper and middle trunk and lower trunk lie behind the scalene anterior, so what do you expect to find? You'll find three structures. Then the subclavian artery is behind the scalene anterior muscle, but at a lower level, it's this one. See that? This is the subclavian artery. So you expect to find four structures. Now let's count here. This is 1, 2, 3, 4, 5 structures. What happened here? What happened here is that the C5 and 6 roots of the brachial plexus, they are long enough to emerge from the lateral side of the behind the muscle. So this is actually C5 and this is C6, and this short segment is the upper trunk, and this is the middle trunk, and this is the lower trunk of the brachial plexus. So this should be the subclavian artery. Please see that? This is very important about the relations of the scalene anterior. This is the look without the zoom. Okay. Now let's go to the scalene medius. Scalene medius muscle, arising also by, I forgot to say that the scaleni, they arise from the anterior tubercles of the cervical transverse processes, the posterior being the lowest muscle of origin. They don't reach high up from the third downwards, from the third vertebra downwards. Only the levator scapulae and sometimes the anterior that might, only the levator scapulae that reaches the levels of C1. The scalene medius muscle, this is the scalene medius muscle. I know it by looking at the structures, the subclavian artery and the brachial plexus. It's the muscle behind them, posterior to them. Of course, posterior to the scalene anterior. This muscle goes to the first and second ribs, outer surface, and it has two unique features. First of all, it's pierced by the dorsal scapular nerve. You'll see a nerve coming out of the muscle and goes back, pierces the levator scapulae and continues backwards. This is called the dorsal scapular nerve or nerve to rhomboids muscle, dorsal scapular nerve. Another nerve pierces the muscle, which is the long thoracic nerve. It comes out at a lower level, goes down to supply the serratus anterior muscle. This nerve is called the long thoracic nerve or nerve to serratus anterior. It's C5, 6, and 7. So you have two nerves piercing the muscle, the dorsal scapular nerve or nerve to rhomboids, C5, and the long thoracic nerve, C5, 6, 7, that goes down to the serratus anterior muscle. The scalene posterior is a smaller muscle. This is part of it showing. It goes further down to rib 3. It has nothing unique about it, except that the fact that it's hidden. Actually, it's hard. You must dissect deep to find it, but it's still part of the floor of the posterior triangle. Now the levator scapula, see these flesh bands coming with tendinous origins from anterior tubercles of transverse processes of cervical spines, upper 4 or maybe 3 or 4 anterior tubercles. This is the levator scapulae. These muscle bands unite together and or may stay ununited and go to the superior angle of the scapula to elevate the scapula. That's why it's called levator scapulae. The levator scapulae, remember that it looks like multiple muscles, and remember that it's pierced and supplied by the dorsal scapular nerve we talked about that comes out of the scalene medius muscle. Okay, so you have scalene anterior, scalene medius, scalene posterior, levator scapulae, and this is the splenius capitis. We're not talking about it because it's muscle of the back. See, part of the semispinalis capitis is showing here. Okay, this is about the floor. The action of these muscles depends. Well, it's think about it. Think about a muscle like thinking about a rope. You are trying to approximate the two ends of the rope together to shorten the rope, shorten the muscle. It's attached to the vertebra upwards and the ribs downwards. Now, if you fix the vertebrae, if you fix the ribs, it will act on the vertebrae. It will lateral bend or lateral flex the cervical vertebral column. So lateral bending or flexion of the neck. But if you fix the neck and contract these muscles, when do you get that? You get that in forced inspiration. When you make an effort. When you try to catch your breath. So this, now you can call it and classify these muscles as accessory respiratory muscles. Accessory respiratory muscles, muscles that work on respiration in certain conditions, not all the time, like the paravertebral muscles, the scaleni, because they're attached to the ribs. If you fix the neck, they will pull the ribs up. That's forced inspiration. Now, the omohyoid muscle, the only thing to mention here now, because it's not its place, that the inferior belly is part of the triangle, and it subdivides it into two other triangles. Now let's talk about cervical nerves. Doctors, please note that I said cervical nerves, not cervical plexus. Nerves is a more general term, cervical nerves. Any cervical nerve, any spinal cord nerve, the typical spinal nerve, arises by ventral root and the dorsal root. This is inside the canal, the vertebral canal. Now, once past the intervertebral foramen comes out, it divides into ventral ramus and dorsal ramus. So when we talk roots, we are inside the vertebral canal. When we talk rami, we are outside the vertebral canal. We are outside the vertebral column after the nerve emerged from the intervertebral foramen. Note that the posterior root carries sensory impulses, anterior root carries motor impulses, and they are distributed throughout the rami. Now, what am I trying to get to here? Dorsal rami of nerves never ever form plexuses. So you have cervical dorsal rami, thoracic dorsal rami, lumbar and sacral dorsal rami. They do not form plexuses. What's their destination? To supply the skin and muscles of the back proper. The back of head, back of neck, and the back proper till the coccyx, back of coccyx. Okay, please, this is very important. The ventral rami of nerves, they are the ones that form plexuses. See, there's a difference between the destination of dorsal rami and ventral rami. So whenever you study a plexus, like cervical plexus, brachial plexus, lumbar sacral plexus, you always start with it's formed by a ventral primary rami of such and such. دايما تلاقي كلمة formed by the ventral primary rami of كذا وكذا. What is that? These are the ventral rami we are talking about, because there are dorsal rami who that does not make plexuses. Now, what's the use of making a plexus? Plexus شبكة, network. So it means that you are exchanging fibers. The plexuses are very important because without plexuses, imagine that every muscle gets its own nerve. So you will need to have a very big cross-section spinal cord to get that, because you need cells that will form the nerve. And since you have nerves for each muscle fiber and each muscle, individual muscles, so this is a catastrophe. Actually, you can't get that with this size. So you need to have a way to exchange fibers. I mean, the muscle gets its nerve supply from multiple segments of the spinal cord. See what I mean? Okay, what else? If individual muscles are getting an individual nerve supply, this means that we will act like robots. حركة تبقى زي robots. No harmony between the muscles. No harmony in action between the muscles, like doing complex movements of any part of your body. See, so it's like it connects the muscles together, and this is very well organized internally in the CNS by several nuclear groups in the spinal cord and centers in the brainstem. So the plexuses are important. Where do you get these plexuses? Well, in parts that you need them. If the neck, we need them to supply the neck, so the cervical plexus. And for the upper arms, we'll get enlargement of the spinal cord at the cervical part and the upper thoracic part to supply the upper limb, and so forth. You will get another lumbosacral enlargement at the lower part to supply the lower limbs. So whenever you get more muscles, you will get more nervous tissue. Let's get to the cervical nerves. Now, we talked about if you have an essay question, discuss cervical nerves. Don't fall in this trap. Don't start by cervical plexus. No. Start by mentioning that you have ventral rami, dorsal rami. Dorsal rami do such and such, and then we come to the ventral rami. Here it forms the cervical plexus. Now, the cervical plexus of nerves, the plexus, the nerve roots, the rami, they join together to form loops on the longus colli muscle and the high up and the longus capitis. They form loops of nerves, and these loops give rise to the numerous branches of the cervical plexus. You can classify it whatever you want, but we have a standard classification. It has superficial branches, ascending branches like the lesser occipital nerve, this one, that supplies the back of the scalp and the ear pinna, sensory of course. We have the greater auricular nerve. Great auricular nerve, it goes towards the parotid. You'll see it going towards the parotid, supplies the parotid capsule and skin over the angle of the mandible. Transverse cervical nerve that divides into many branches to cover the area of the anterior skin of the neck. And descending branches, which are the supraclavicular nerves, mainly C3 and 4. They go to supply the skin over the pectoral region, clavicle, and the shoulder. And we talked about the lateral group and the significance of its overlapping C5 of the upper limb. These are the superficial branches. Deep branches of the cervical plexus. Now, next lecture we will talk about little about the autonomic nervous system, the sympathetic, especially the sympathetic, and how it works. We have what's so-called gray rami and white rami communicantes. Now, to get the idea, the gray rami communicantes, it distributes sympathetic flow to all the body. So you expect all spinal nerves, starting from cervical down to coccygeal, they receive gray rami communicantes from the corresponding sympathetic chain. While the white rami communicantes, these are the ones who bring power actually from the CNS cells, the autonomic cells in the CNS, in the lateral horn of the spinal cord. These bring the power to form the sympathetic chain via the anterior root of the nerve. We will discuss this later. So you have only white rami in the regions where you will find the power switch, which is all thoracic spinal cord segments and upper two lumbar segments. That's why T1 through L2 receives gray and white rami communicantes, while all the rest of the spinal nerves only receive gray rami communicantes. See those tiny areas? See the tiny branches, see those tiny branches? These are the gray rami communicantes coming out of the upper or superior cervical sympathetic ganglia. There it is. Very well, nicely dissected in this area. So to recap what we just said, deep branches are the first group of the deep branches are the gray rami communicantes coming out of the superior cervical sympathetic ganglia to spinal nerves. What else? Muscular branches. The pre and paravertebral muscles, they receive direct muscular branches from this plexus. Don't forget, we have the dorsal scapular nerve as well. In addition to the branches of the cervical plexus that supplies the levator scapulae. So don't just stick it to the cervical plexus for the supply of the levator scapulae. It has direct branches from the cervical plexus as well as the dorsal scapular nerve, which is C5, that additionally supply the muscle. Don't forget this point, please. Okay, what else? We have communicating branches with other nerves other than spinal nerves. For example, the hypoglossal nerve. C1 gives an extension to hypoglossal nerve as it emerges from the skull, from the hypoglossal canal. These fibers coming from C1 are destined to form what's so-called the ansa cervicalis for the thyroid and genohyoid muscles. So, in spite that the fact that the hypoglossal nerve is a cranial nerve, it gives off branches that does not belong to the nerve itself. It belongs to other nerves, like in this example, C1, and we will take a good look at the ansa cervicalis when in the anterior triangle with the infrahyoid compartment. So to recap, we have communicating branches with other nerves, like the hypoglossal. There are communications with 9 and 10, by the way. Muscular branches to the pre and paravertebral muscles. The sensory branches, proprioception, C2 and 3 for the sternomastoid, and C3 and 4 to the trapezius, sensory, proprioception, and the greater mi communicantis we talked about. Now, last but not least, in the posterior triangle, we have the third part of the subclavian artery. Of course, the artery continues as the axillary artery in the upper limb, and we will talk about its branches in detail in next lecture, because we will have a topic called the subclavian artery. But remember that some of the branches of the artery, although it arises in the anterior triangle, it crosses on its way back. That's why it's a content of the posterior triangle, like the superficial transverse cervical artery, the suprascapular artery, are arteries that belong to the posterior triangle. The subclavian vein, it's a continuation of the axillary vein and ends by joining the corresponding internal jugular vein to form the brachiocephalic vein. This is the end of this lecture. Thank you for listening.